Welcome. Thank you so much for coming. My name is Meghan Swyryn. My pronouns are she, her, and I am a third-year medical student at Temple University. And I am joined by several members of SNaHP National, and we are so excited to talk to you today about Single Payer 101. So I'm going to start off with the state of affairs in the US healthcare system and also touch a little bit on how COVID has revealed our need for Medicare for all. So the US spends more money on healthcare than many other countries with universal healthcare systems. I'm sure when you're talking to people about single payer and why you support it, a really common criticism is the expense, but we are already paying a lot of money for our current healthcare system. So I like to think of it as maybe a better question is that we should be asking ourselves is, how much does it cost to maintain our current healthcare system, and can we afford that? It really looks like we can't. So let's look at what that expense gets us. We are actually not doing very well compared to other countries. I'm sure a lot of us have been raised with a lot of American exceptionalism that has been taught throughout our education, but our life expectancy at birth is a lot lower than other countries, and our infant mortality is really high. So maternal mortality is rising in the US, but it's decreasing in other countries. So another real challenge we're facing in our healthcare system that is not adequately addressed by our for-profit healthcare. So preventative care. Only 8% of adults over 35 get all recommended preventative care. I saw a really interesting study recently in cancer that mentioned that shows that cancer diagnoses spike at 65, which means that people are waiting until they turn 65 to get Medicare to actually go get screenings for cancer. So I think that's a really big failure of our preventative health services. So even if you have insurance, you might not have insurance that adequately covers all of the care that you need. And you might still have really expensive copays. So nearly half of American adults under 65 remain either uninsured or underinsured. So underinsurance is your annual out-of-pocket expense is greater than 10% of your income, or if your income is less than 200% of the federal poverty level, and out-of-pocket expenses are greater than 5% income, or deductibles are greater than 5% of your income. So now let's talk a little bit about COVID. I know everyone has probably heard a lot about COVID in the past year, so I don't want to focus on it too much because I know everyone's a little burned out from it. But our private insurance system has really hindered access to care. So this is an table from a really amazing public citizen study that I really recommend you check out. The link to it is actually on the next slide. The estimated impact of health insurance gaps on total COVID-19 cases and deaths. So a recent study found that 1/3 of COVID-19 deaths and around 40% of infections were linked to a lack of health insurance. For every 10% increase in a county's uninsured rate, the researchers found that a 70% increase in COVID-19 infections and a nearly 50% increase in deaths from COVID-19. So our private insurance system has really made this pandemic so much worse. Next slide. So even if you do have insurance, or even if you do have a job, you might not have adequate insurance to get your care. And these are a lot of really important jobs in our society. I think that we've all seen so many thank you essential workers. Every time you go to the grocery store, you probably see a heroes work here sign. And it's really frustrating that the people who have been holding our society together have not been adequately cared for. So this is the uninsured rate by employment category for frontline industries. I am originally from Orlando, so this definitely hits a little close to home for me because so many people in my hometown work in tourism. A lot of people work in low-paid jobs at Disney or SeaWorld, and they don't get insurance. So this is another, sorry. Nope, I am all done. Thank you so much. Take it away.
All right, so why is our system so broken? Well, as you can see from this image, we have a very fragmented system with a mixture of public and private insurance with thousands of different plans. And that means that hospitals and providers have to put in a tremendous amount of manpower and time to make sure that they're reimbursed. And this is what we refer to as administrative overhead or administrative waste. Studies have found that each doctor needs at least 2 billing assistants to make sure that they get reimbursed for the care that they provide. And administrative waste accounts for 34% of our healthcare expenditure. And that waste, of course, includes the profit that private health insurance companies collect to pay their CEOs billion-dollar salaries. So in general, our system is incredibly expensive without providing care for everyone. And in not providing care for everyone, we lose around 40,000 Americans a year due to lack of insurance. And these numbers are before the pandemic. And as Meghan highlighted, many lives have been lost during the pandemic due to lack of access to care. And as Meghan also pointed out, we have terrible life expectancy, infant mortality, maternal mortality in this country. But when you actually look at the numbers, Black Americans have higher rates of infant mortality and maternal mortality than white Americans. So the system disproportionately affects people of color. And as you can see with these charts, these disparities don't just stop there. We have disparities in outcomes from HIV diagnoses and teen pregnancy to diabetes and complications from chronic conditions such as diabetes and heart disease. So in general, Black Americans are more likely to be reported as having fair or poor health status and facing challenges that affect their health and access to care. And even if Black Americans have access to care, there's a disparity in where they get their coverage. Black Americans are more likely to be on public programs such as Medicaid, which restricts their access to care as it restricts the provider pool that they can see and delays their care. And delaying care has expensive outcomes. As you can see, delaying care due to waiting times from narrow networks or also due to high deductibles and high out-of-pocket expenses leads to worse health outcomes. It leads to a higher likelihood of ending up in the ER in a worse condition and hence needing a more financially expensive intervention. Delaying care has also resulted in diagnosing breast cancer later and increased mortality from breast cancer, especially in Black women, and has led to complications from chronic diseases such as heart disease and diabetes, which can lead to chronic kidney disease, amputations, and really affect quality of life for these individuals. And our system not only makes it hard for people to get care, but when they do, they face financial hardships because of the out-of-pocket expenses. About 20% of a regular family's income can be taken up by premiums. And the number one reason people file for bankruptcy is medical debt. About 68% of people that file for bankruptcy is due to unpaid medical debt. This means that everyday Americans are making a decision between getting necessary medical care and between getting care or paying rent, putting food on the table, paying for education and bettering their job opportunities. And that's not right. So how do we fix this broken system? The only solution that ensures that everyone is covered and able to access care and decrease the tremendous cost of our current system is a single payer Medicare for all system. And as you can see, administration would be very streamlined. People and businesses would pay taxes that would then fund healthcare expenditure. And the coverage would be very comprehensive. It would include preventative care, dental and vision, which is not covered by most insurance companies currently, reproductive services, medications, but also importantly, long-term care, as we have an increasingly large aging population that needs care at home or nursing homes. Most seniors end up going bankrupt paying for care even under Medicare, to the point where they end up on Medicaid, which does cover long-term care. And the best part is that there's no cost at the point of service. No copays, no deductibles, no premiums, and no one will be receiving a bill in the mail months later with surprise charges. So economically, this will also be very wonderful for the country. We will save around $500 billion annually in cutting down administrative waste. And 95% of Americans will see their healthcare expenditure go down, since we will cut out copays, premiums, deductibles, and pay for this through progressive taxes. So those with more can afford to pay more in taxes. And with the bargaining power we will have under one plan, we will be able to stop the money that we waste currently on high healthcare costs, as hospitals currently can charge ridiculous amounts for regular procedures and small things because private insurance and Medicare does not have the power to bargain that down. And also it will allow us to bargain for lower drug prices, as Americans currently pay more than any other country for medications, the same medications and the same brand from the same companies. We pay the most.
So I'm going to just give some updates on where we are with Medicare for All legislation. And so if we look nationally, there are bills in both the Senate and the House of Representatives for a national Medicare for All plan. And so actually the Medicare for All bill was just reintroduced in this Congress a couple weeks ago, and this bill is given the number HR 1976, and this is the Jayapal bill. And there are now 114 co-sponsors of this legislation, which, if you're new to the single payer movement, you should know that this is a huge accomplishment, because now we have the majority of House Democrats as co-sponsors of the bill. So it's come a long way from where it was just a few years ago. And the Medicare for All Act of 2021 in the House is co-sponsored by 14 committee chairs and several key leadership members. And again, that's really significant because in past Congresses, Medicare for All had a lot less co-sponsors and not a lot of co-sponsors from members of the leadership. Now in the Senate bill has not been introduced in this Congress, but in the last Congress, it did have 14 co-sponsors, and this is the quote-unquote Sanders bill, and we expect it will be reintroduced in this Congress as well. Now, there are a few updates I want to point out. The first is down here, you can see this was taken from a news article, and it is saying that New Jersey Representative Frank Pallone is now a co-sponsor of HR 1976. And this is really significant because Representative Pallone is the chairman of the Energy and Commerce Committee. And if this bill were ever to get to the floor for a vote, it does have to go through the Energy and Commerce Committee and have hearings and markups. So the fact that he's now a sponsor, he was not in the last Congress, is really significant. And not only that, but he has committed to giving HR 1976 a hearing in the House Energy and Commerce Committee in this current Congress. And again, that's really significant because if we ever want Medicare for All to get to the floor for a vote, it has to go through that hearing process in committee. I also want to mention that the new bill has emphasized the just transition for impacted workers. So we are going to make sure any workers who are displaced by the closure of private insurance companies have the means to transition into alternative employment. And this bill would also establish an Office of Health Equity, which, as Krita and Meghan mentioned, COVID has made just glaringly obvious that we need more focus on health equity in our current healthcare system. And I also wanted to mention that this bill specifically states that the Secretary of Health and Human Services can add benefits but cannot remove them. And that's really important because you can imagine a world in which we get Medicare for all and then we have an administration that perhaps wants to remove benefits. This would ensure that we won't have that happen once we get a Medicare for all system. And so we also have a lot of legislative activity going on at the state level. And so while our goal is national Medicare for all, 18 states have actually introduced single payer legislation. And so here is just some cutouts of those different states. So we have Minnesota, we have California, we have Colorado, we have South Carolina, and we also have New York. And I am was a student in New York, and so I'm very familiar with New York's plan. But overall, these state plans would essentially create a single payer system within the state. And again, while our goal is national, these state plans can also help educate further people about what Medicare for All is and why we need it, and could possibly be a model for later Medicare for All. And so there's also a lot of movement on the local level. And there is an incredible campaign by Public Citizen to get resolutions in support of Medicare for All passed on the township or city level. And here's a map just showing where these resolutions have been passed, where they are ongoing. And you can see that there's a lot of those green dots, meaning a lot of these towns have passed resolutions in support of Medicare for All. And this is useful in talking to House reps and senators about why they should support Medicare for All, but also a lot of the elected officials in these localities will go on to hold higher offices, such as being House members or senators. So it's very helpful to make those relationships with them early on.
Now, of course, with such bold and transformative legislation, you're going to have opposition. And in our case, it's the Partnership for America's Healthcare Future. The group includes, as you'd expect, private health insurance companies, big pharma, hospitals, and some doctors. They have lots of money for ads, lobbying, etc., but they don't have the people power that the single payer movement does. In fact, SNaHP and PNHP were actually able to get the AMA to leave the partnership using direct action and public pressure. And if you'll go to the image, here you can see SNaHP and PNHP members showing up at the doorstep of the AMA in protest. 2,000 people showed up, and eventually the AMA conceded. Now, with the new administration, the partnership rebranded, and they are now the Affordable Coverage Coalition. They have to balance pretending to care about affordable coverage while trying to preserve the interests of the private health insurance industry. And you can see that with who the groups in the coalition are, like like America's Health Insurance Plans, AHIP, Blue Cross Blue Shield Association, and more. In the next image. Ultimately, these groups are the same mafia that will attempt to squash any proposal to make healthcare in the United States accessible, practical, and moral. Now, the thing to know about public option, there are many different proposals of what public option or Medicare for All who want it would look like, and some are better than others, but all of them have the same key issues as you can see in the red. They don't provide any healthcare savings to offset the cost of covering everyone. And in this case, we can justifiably say we can't pay for it. Public options will also likely self-select for the most vulnerable populations, leading to higher costs, while for-profit insurance companies have pools of lower-cost people, which makes it difficult for the public option to compete and to survive. Now, Congresswoman Jayapal's HR 1976, the Medicare for All Act of 2021, is the only healthcare bill in Congress that would provide universal healthcare, would fully cover all benefits, and would eliminate cost sharing, which are copays and deductibles. And as we discussed, public option as a concept may sound good, but from every angle, it is bad policy. David Himmelstein and Steffi Woolhandler, who are the co-founders of PNHP, wrote an article that outlines the problems with public option plans that rely on or maintain private health insurance, including Medicare Advantage plans. One, obstructing expensive care. Private plans market themselves as covering health care, but will really only cover minor services, and even that, there are exceptions. They deny any health care that threatens their profits. Second are cherry picking and lemon dropping, which is selectively enrolling people who aren't that sick and dropping anyone who's too ill, which for a healthcare system sounds really counterproductive. Upcoding is the third characteristic, which is making enrollees look sicker on paper than they really are in order to increase premiums. And fourth, lobbying to get excessive payments and to thwart regulators. If a public option is implemented that allows private insurance to thrive, but introduces a competitor with the public coverage, you bet they're going to use everything in their arsenal to attack, defund, and dismantle it. It'll never be a playing field with them in the game.
So now that you have gotten an introduction into what Medicare for All is and why we are fighting for it, we want to let you know how you can get involved. And so first is you can join SNaHP, which is Students for a National Health Program. And this slide just shows some of the highlights of things that SNaHP students have done in the past few years. And so we do a broad range of different activities. So this can be educating our fellow classmates about what Medicare for All is and why we should fight for it. We also write op-eds and letters to the editor in our local papers and national outlets, again, explaining why we as students believe that we need Medicare for All. And we also do lobbying visits to our elected officials to discuss Medicare for All. And also, once it's safe after COVID, we do in-person canvassing to, again, just get out into our communities to talk to them about what their experiences have been with healthcare and how we can make a better system and why that should be a single payer system. And so here are some resources for how to get involved, including starting a SNaHP chapter. So if you find yourself at a school or in an area that does not have a SNaHP chapter, we fully support you starting your own chapter. And so we do have a chapter startup guide, and the link will be dropped in the chat. And this takes you step by step in how to start your chapter, what events to host in your first year, how to recruit members, and other things you'll need to know. And with for guidance as you start your chapter, feel free to contact us at students@pnhp.org, because we have an entire team dedicated to helping people start and develop their chapters. So we are here as a resource for you to use. We, in the recent years, have also gotten tons of interest from high school and undergraduate students. And we do have a new chapter that has formed with those students. So if you do find yourself either not at a medical school or dental school or other health professional school, but you still want to get involved, we really encourage that as well. And again, as I mentioned, we also encourage getting involved in passing resolutions in support of Medicare for All, whether it's on a local level or also in your prospective specialty societies or other medical associations. And that link is here again, and all these links will be dropped in the chat. And we also encourage you, again, if you don't have a SNaHP chapter or a PNHP chapter near you, there are so many other groups in a broad coalition fighting for Medicare for All that we've highlighted on this slide. And we really believe, as is the theme of this summit, that we really need to unite into a very strong and broad coalition to make this change, because it is going to be a huge change from the private, cruel healthcare system we have right now. And we believe that we need to work together and make a huge people-powered movement in order to make this a reality. So we encourage you to get involved with all of these coalition groups as well. And so now we have some time left, and we are happy to take any questions you may have about the facts of Medicare for All, how to get more involved, any questions. So feel free to drop them in the Q&A feature and we will answer them.
And feel free to raise your hand and let us know if you've got a question.
And I'm going to share slides with other pertinent links while we go through Q&A. So I see we have one question asking, how far are we from passing the single payer bill, which is the New York Health Act in New York? I think we are a lot closer than we were a few years ago. We now have a majority of co-sponsors in the Assembly and the State Senate. And we definitely think that's a lot of progress, but we still need incredible pressure on our elected officials for them to bring it to a floor to a vote and eventually for the governor to sign it. And that's why, again, we're really happy that we have such a huge movement of students. And we also think we are going to need to work with all the other groups on the ground in New York and even get some help from other states in order to fully pass it. But I definitely think we are making a lot of progress.
Yep, we're getting some questions in the chat. In terms of good resources for continuing to educate yourself, SNaHP and PNHP provide a lot of wonderful resources. If you go to our website, you will find quite a few single pagers, fact sheets that you can read through, but then also share with your legislator and representative or family or friends to educate them as well. So definitely visit our website, student.pnhp.org. and or pnhp.org. There are many resources there, and usually they're very concise, single page topics that you can read through to really understand how it'll affect racial disparities, how it'll affect our preparedness for another pandemic, and in general what Medicare for All is.
So I see another question in the Q&A. Do you think Medicare for All implementation will look different in different states? I think this is a very important question because I view the fight for Medicare for All as continuing through passing the bill, right? Because once we pass the bill, we have a lot of work to do to make sure that we are able to fully implement it in every single state. And as we've seen with the states that chose not to expand Medicaid and actually have legislatures that are actively fighting against it, I do think in some states there will be resistance and opposition, and we have to make sure that we are pushing to implement it as the bill is designed. We don't want to build a Medicare for All system with further health inequities in it. And so I think there's potential for it to look different in different states, but that's going to be part of our job in kind of phase 2 of the fight for Medicare for All once we've passed the bill, to make sure that we are implementing a just, equitable health system. So our work will continue on that.
And on that note, the question about incremental reforms, a public option versus just expansion of Medicare to cover vision and dental. As Rachel mentioned, we want to make sure that we're not working backwards, that we're continually pushing forward. So any change that does expand coverage, that does expand access of care to more people is good and will be something that we support. So if there's a bill in place that expands Medicare coverage to include vision and dental, then we're all for it. Again, we want to be pushing forward to eventually become universal healthcare, covering all issues and everyone. So any incrementalism that moves us towards Medicare for All eventually is good.
I'll add one quick point about the incrementalism question. That's why we went in a little more detail about some of these different public option plans, because there's a wide variety of public options that accomplish different things and also put the ball in a relatively more improved public system versus a much more privatized system. Ultimately, we want to move the ball towards more public, so that a lot of that looks like strengthening Medicare, existing Medicare, and increasing people's confidence in current Medicare. We want the slogan Medicare for All to stick, and if we're making Medicare better and better, it increases trust in the program, although ultimately our goal is far more expansive than anything that current Medicare encompasses. But we absolutely don't want to move the ball backward and end up with a much more privatized system, such as what is currently developing at breakneck pace with all the Medicare Advantage plans, where private insurance companies administer or provide Medicare, but in a privatized way with market logic. That's absolutely not the direction that we want to go.
All right, we got some more questions in the Q&A. Someone asked, is there a planned date for the next vote on the bill? So currently there is no date set for when the bill will be brought to the floor for a vote. As Rachel was explaining before, it will need to go through committee hearings and be pushed through by committee before it can come to the floor for a vote. So in terms of advocating to push it through, we're working on specific legislators that are in these committees, Ways and Means, Energy and Commerce, to show them the benefits of Medicare for All, help them understand and push them towards having a hearing so the committee can then push the bill into the floor for a vote.
I see another question asking, how do we push hospitals to support Medicare for All? I find the increasing encroachment of private equity, mergers, and consolidation very scary, making the American Hospital Association a huge opponent. I wholeheartedly agree. I think we need to get the hospitals on board. And I think that's going to start with us as students and future health professionals in really putting pressure on our hospital leadership to make sure that they are, one, not opposing Medicare for All, because right now a lot of large hospital systems do oppose it. And two, we need to use our power as members or employees of those hospitals to make those sorts of policy changes that we want to see. And we will have a labor panel later on talking about organizing of some healthcare workers. But I think that's just another place that we need to focus our organizing energy. And we can do that through storytelling of what we have seen either as patients or as providers, and also in terms of, again, putting pressure on our hospital leadership. So I think that is a big task for us to do, but I think as the providers in hospitals or future providers, we do have a lot of power there that we should learn how to focus toward getting hospitals on board with Medicare for All, or at least getting them to move out of the way and not be obstacles.
I saw a question about how do state efforts to pass single payer, such as the New York Health Act, support national Medicare for All efforts? I think that's a really great point. I live in California and we have CalCare, the California Guaranteed Healthcare for All Act. And the really important thing to remember is that pushing for state bills does not mean we cannot push for national bills. Pushing for both at the same time is the ideal strategy. And in fact, trying to mobilize people for a state bill gets them excited about the idea of single payer healthcare as a whole, and therefore you get more support and more pressure that way. Another thing is that if, for example, New York or California or any of the other 18 states pass single payer healthcare and they get better results than the United States as a whole, and you can start to see it in their healthcare system, that is absolutely going to push the public and elected officials to say, this is something we need on the national level because we've seen it work in a state. So I think passing it in states is a really good way to get to mobilize people for a national bill. And it's also how Canada did it.
And I'll just add quickly onto that. I think, when we're talking about organizing around a state single payer bill or a national bill, at the core, we're talking about the same thing, right? We're talking about everyone having a right to healthcare. We're talking about single payers. So we're just educating people on Medicare for All in general. So we're just building the movement, whether you are talking about state or national bills. And so I think either way, it's again, just making us stronger as a movement.
So there was a question about how would you argue against the public option when there are benefits in terms of increasing access, but as side effects possibly poisoning the concept to Medicare for all. So I think this brings up a good point of talking about coverage versus access. So you might be covered because you have a health insurance plan, but do you actually have access to care if you can't, meet the deductible and, pay the copay, et cetera? So a public option can provide some people coverage that don't have coverage currently. So that means they've signed up for a health insurance plan. They have money taken out of their paycheck every month for a premium, but can they actually go and see the doctor if seeing the doctor and the resultant imaging or medication would be very expensive because first they have to meet the deductible to be able to get the rest of their care covered by health insurance. So I think it's very important to point out that public option might increase coverage, but not necessarily access to care. And again, as we mentioned before, all the other problems with public option in that it won't get rid of the private industry. And as we've seen with Medicaid and Medicare plans that have been administered by private insurance companies, if that happens, we'll see the same issues that Medicare Advantage has, in that it costs more but doesn't necessarily provide good care or health outcomes for the people it serves. So anyone else have anything to add to that?
I'll just add, and Krita, you touched on this, but I think, if we find ourselves in a political reality where public option seems like it's bound to happen no matter what we do, we need to make sure, again, and I think Rex mentioned this as well, that it's not a step back, it's a step towards single payer. And so again, we don't want a public option, quote unquote public, but that is administered by private health insurance companies, because that's just going to give them more power and create a terrible option, not really a public option. So if it seems inevitable, we then need to make sure that it's not a step backwards and it's a step forwards, a truly public option administered by, say, CMS or something that can serve as a stepping stone toward Medicare for all. And I think, you can phrase that as saying, well, sure, it's going to expand coverage, and if it's truly public, maybe it won't be that bad, but here are all the reasons Medicare for all is better. So it's definitely a tricky situation to find ourselves in, but we just have to make sure it's not a step back. I see a question, how do we prevent the bill from getting buried in committee? Do you predict a floor vote on the bill before the 2022 elections? So I think this is a really important question. And I think the hearing in the Energy and Commerce Committee is a big step, because for a bill to be voted on the floor, you need to have a hearing, at least in the full committee, but sometimes even in the subcommittee. And then you also need to have the bill marked up in both the subcommittee and the full committee. And to do that, you have to put pressure on the committee leadership. And so I think having the chairman of the House Energy and Commerce Committee on the bill is really important. I will note this bill will go to other committees as well, like Ways and Means. So we need to keep putting focused pressure on those committee leaders, because again, it can get buried in committee if the committee leadership is not fully on board with it, because again, there's a lot of steps that it has to go through to get a vote. I think if the hearing is strong for Medicare for all and it goes really well, and we keep putting pressure on committee leadership, then there is a very good chance for the bill to move forward. I think we're in a much better position than we were before, when again, we didn't have these 14 committee chairs on board and as sponsors of the bill. So I think there's a lot of procedural steps that sometimes are frustrating because it takes so long to get something to the floor for a vote. But I think we are well on our way and in a lot better place than we were in the previous Congress. And so if we just strategize on our political targets, I think we will see that work pay off.
Yeah, I mean, in comparison, in the previous Congress, the subcommittee of health under Energy and Commerce had a hearing, and it wasn't just for Medicare for All, it was to look at all proposals for universal coverage. So now that we have a specific Medicare for All hearing with a bigger committee is definitely a big step in the right direction. And so we just kind of have to keep on pushing it forward this way.
I see a question. Have there been state bills addressing using global budgets like in Maryland and Pennsylvania? And so that's a good question. Global budgets is something that we didn't quite touch on in this session, but I'll just explain very briefly. And so under Medicare for All, we as PNHP believe the best way to budget for hospital systems would be something called global budgets. And essentially, this would mean that hospital systems would receive a lump sum or a global budget for their costs for patient care based on the volume of patients. And if they had any extra money at the end of the year, they'd have to give it back. And so in this way, we could make sure that hospitals aren't preferentially treating higher cost patients or VIP patients who they know can pay more, because they will get, again, a global budget based on simply the volume of patients. And it will also help to fight health inequities, because again, we won't have, hospitals in low income areas having less revenue compared to hospitals in high income areas. So it will take the incentive and kind of the business like aspect out of patient care. Now, I do know some state bills, at least in New York, the ultimate goal is to operate on a global budget system, but I don't know if there are state bills that specifically address using global budgets or even talk about using global budgets separately from a single payer system. I know there has been some movement, but I'm not an expert on those state bills. But I know that we at PNHP and SNaHP do believe that global budgets are the way to go. And again, the way to turn our health system away from a business model, fee for service, and more toward a health actual care system.
All right, we have a few more minutes, so we have one more question that Meriam will answer.
Yeah, I wanted to take a stab at this one. I think it's really important to understand for less progressive regions of the country that haven't expanded Medicaid under the ACA, that there's a lot of popular support for this, and it can come from the most unexpected places. So I'd say that in this case, I think working towards getting public support for at least something as basic as expanding Medicaid is an important step forward. And if pushing for something that isn't as something that's as big as single payer healthcare may not be the path forward at the moment, I'd say at least pushing for people to understand the problems with the current healthcare system, and then mobilizing them to take action on that will create those will basically blaze the path forward for more action, because expanding Medicaid, we know it's not enough, and we know it's not going to be enough. So that's what I'd say for that. But good, thank you for working for less progressive regions of the country. It is really a travesty there.
Yeah, no, exactly. Oh, sorry, go on, Rex.
I was going to say, SNaHP and PNHP have some really, really wonderful resources and partnerships for tailoring your advocacy in some of these less progressive regions of the country. Some of our best physician advocates in PNHP come from red states. I'm thinking in particular of Dr. Ed Weisbart from Missouri. He's done a whole series about the political communication for Medicare for All, and how you need to think about what are the political values that your possibly more conservative opponents might espouse. It's going to be different from the usual empathy sort of justice framing that we like to focus on, a little bit more about like improving America's pride in its healthcare system, or appealing to these more traditional values, so to speak. But there's definitely a way to tailor it. And I'd also point to resources from Business for Medicare for All, that's led by Wendell Potter. He was formerly working for the insurance, for the insurance industry, and has since joined the Medicare for All movement and is trying to strengthen the business case for Medicare for All. So that's also a really incredible resource. I think that the economics of this program completely check out. It's mostly just about being able to become even more effective political communicators on our own side.
Yeah, and talking specifically about messaging, there is a PNHP link that's specifically about making the case for single payer to conservatives. And I think it's just a great way of, communication. It really outlines why single payer healthcare isn't a liberal policy, isn't a conservative policy. It's a humane policy, it's practical, and it's effective. And that's exactly what this page communicates. I put it in the chat.
And real quick, I think that when thinking about areas that are often labeled as less progressive, it's not the people that live there that are less progressive. They're often saddled by really harsh, gerrymandering and voting laws. So it's really, we're not all that different. As someone who grew up in a very red area and am now part of a very bright blue dot in a very red state. So, it's not as black and white as, we think of, progressive areas and conservative areas. Everyone wants healthcare. Every single patient I've ever spoken to is frustrated at how confusing the process is. And I find the process confusing too, even though I am learning through it. And, I'm in one of the bluest districts in the country, and my rep has not actually gave up on Medicare for All after getting some Blue Cross Blue Shield money. That is Dwight Evans. So definitely tweet at him and fill up his voicemail box.
Great. So I think we are going to end there. Thank you everyone who tuned in to Single Payer 101. We will be continuing on this same Zoom link. So we will have a break right now. You can turn off your mic and video, and we will come back to start the next session at around noon Eastern time. And we look forward to seeing you then. So thanks everyone. And if you have more questions, feel free to continue to ask them throughout the day. And I do want to mention, we put in a link on how to join SNaHP. So even if you join through your school chapter, you do need to log on to our national link and make sure you join through that link so that you're getting our emails, e-blasts, and things like that. So we will see you in a few minutes. Thanks everyone.